Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Eating Disorders and Substance Use, and our presenter is Dr. Kelly Ramsey, Chief of Medical Services for New York State OASAS. She'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks, Dean. Let me go over our learning objectives for today. We're going to be discussing eating disorders and substance use disorder. So first, we'll go over some quick facts on eating disorders, including risk factors and screenings for eating disorders. We'll discuss binge eating disorder, anorexia nervosa, and bulimia nervosa in detail, including DSM-5 criteria, potential symptoms, epidemiology, potential health consequences, and treatment options. We will briefly discuss other eating disorder diagnoses. We will discuss the relationship between eating disorders and substance use, discuss eating disorders and co-occurring mental health diagnoses, briefly discuss identity and eating disorders and the COVID-19 pandemic's effect on eating disorders, briefly discuss types of psychotherapy for eating disorders, briefly discuss prevention for eating disorders, briefly discuss evidence-based treatment for eating disorders in general, and provide a summary of additional statistics and research on eating disorder. First, some quick facts on eating disorders. So this is an image showing normal versus disordered eating. And just like substance use disorder, it occurs on a continuum. So on the left-hand side of the continuum, we have what would be considered normal. So that includes healthy weight, healthy eating and exercise, and a good body image. As we move along the continuum, you can see that it becomes disordered. So next we have weight and shape preoccupation, yo-yo dieting, and excessive exercising. Following that, you may see fasting, compulsive overeating, steroid use, or muscle dysmorphia. Further along, we may see distorted body image and perhaps misuse of laxatives. Finally, we reach the eating disorder diagnoses, including anorexia nervosa, bulimia nervosa, and binge eating disorder. Let's look for a moment at the estimated global prevalence of eating disorders. On this image, which comes from a study that was published in The Lancet in 2021, we have the chart separated by gender, male versus female. We also have it separated by specific eating disorder diagnosis, including anorexia nervosa, bulimia nervosa, binge eating disorder, and OSFED, which I'll define in a few minutes, and also divided by age. So when you look at this image, you can see that there are far more females with diagnosed eating disorders than there are males. You can also see that OSFED is actually the most common eating disorder diagnosed in women, while binge eating disorder is the most common eating disorder diagnosed in males. Despite OSFED being the most common eating disorder in women, you can see that there is also a significant population of women with binge eating disorder. So this is similar to the prevalence of substance use disorder globally. So we see it highest in high-income countries with individuals diagnosed with eating disorders, but there is a trend towards an increased eating disorder burden observed globally, particularly increasing more recently in South and East Asia. Next, we're going to talk about risk factors for eating disorders, and I'm going to read the quote at the bottom. Eating disorders are an irrational and unhealthy means of meeting rational and healthy needs. So first, let's talk about some risk factors for eating disorders. So eating disorders can affect people of all ages, racial and ethnic backgrounds, body weights, and genders. And eating disorders frequently appear during the teen years or young adulthood, but may also develop during childhood or even later in life. Researchers are finding that eating disorders are caused by a complex interaction of genetic, biological, behavioral, psychological, and social factors, very similar to substance use disorder vulnerabilities. Researchers using the latest technology and science are trying to better understand eating disorders. One approach involves the study of human genes. Eating disorders do run in families, and researchers are working to identify DNA variations that are linked to the increased risk of developing eating disorders. Brain imaging studies are also providing a better understanding of eating disorders. For example, researchers have found differences in patterns of brain activity in women with eating disorders in comparison with healthy women. This kind of research can help guide the development of new means of diagnosis and treatment of eating disorders. I'm not going to discuss genetics or brain imaging studies beyond this short snippet here, as it's not quite ready for prime time with respect to eating disorders, but I wanted to mention it so that people are aware that there is research going on in those realms. So continuing discussing risk factors for eating disorders. This was an umbrella review looking at published meta-analyses. So the objective of this study was to grade the evidence about risk factors for eating disorders, specifically looking at anorexia nervosa, bulimia nervosa, and binge eating disorder. And then they graded evidence from convincing to weak using established criteria. So what were the results of this look at meta-analyses? So based on a systematic review of observational studies, 9 studies ultimately were included, providing evidence on approximately 50 risk factors for eating disorders. Over 29,000 subjects with eating disorders and over 1.6 million controls. Though no association was supported by convincing evidence, highly suggestive evidence supported the association between childhood sexual abuse and bulimia nervosa, so that was a risk of almost 3 times normal, and between appearance-related teasing victimization and any eating disorder, again, a increased risk factor of almost 3 times normal. Suggested weak or no evidence supported 11 of the associations, 29 of the associations, and 8 of the associations, respectively. So in conclusion, the most credible evidence indicates that early traumatic and stressful events are risk factors for eating disorders. So very similar to trauma and early abuse and stress being risk factors for substance use disorders. Larger collaborative prospective cohort studies are needed to identify risk factors for eating disorders, particularly anorexia nervosa. This is a very wordy slide, so I'm just going to walk us through the highlights of this study. So this was a study looking at unhealthy weight control behaviors, such as laxative or diuretic use or diet pill use or self-induced vomiting to control or lose weight, and its correlation or relationship with substance use among adolescent girls. And really what it's going to be talking about is the harms of weight stigma. So this was a prospective, population-based longitudinal study of adolescent females over 10 years old. So this included over 1,100 females, 52.7% of whom were non-white. The mean age at the study initiation was just under 15 years old, but there was a range between 11 and 18 years old. They were from diverse socioeconomic status, and the mean BMI, our body mass index at baseline, was 22.4, which was normal. And the mean BMI at 10-year follow-up was 26.2, which would be in the overweight category of BMI. So what were the measures that they assessed in this study? They looked at gender, unhealthy weight control behaviors that I mentioned above. So that would include laxative, diuretic, or diet pill use, or self-induced vomiting to control or lose weight. They looked at substance use, weight stigma, and perceived harms. So this means that they were teased or made fun of by peers or family about weight and how much that actually bothered the individual. Concern about weight and depressive symptoms. So they split the participants into 3 groups that were characterized by their experiences with weight stigma. So group 1 experienced no weight stigma. Group 2 experienced weight stigma, but they did not get very bothered by it. And group 3 experienced weight stigma with perceived harm. So in other words, not only did they experience teasing or being made fun of about their weight by peers and family, but it bothered them. That's group 3, and that's the important group to remember. So what were the results of this study? So the adolescent girls in group 3, so this is the group that experienced weight stigma with perceived harms, reported significantly higher mean of these unhealthy weight control behavior scores. They also had increased weight concerns and depressive symptoms, and they had higher baseline and follow-up BMIs or body mass index in comparison with the girls in groups 1 and 2. The girls in group 3 also had significantly higher baseline substance use compared with group 1, but reported no baseline substance use differences compared with group 2. The adolescent girls in group 1, so this is the group that experienced no weight stigma, had significantly higher socioeconomic status scores compared with girls in groups 2 and 3. So then they did some regression analysis of these groups to further tease out the relationships between all of these variables. So what they found was that girls who had unhealthy weight control behaviors, so laxative or diuretic or diet pill use or self-induced vomiting to control or lose weight, so girls that had those behaviors at baseline predicted substance use at 10-year follow-up among girls who experienced weight stigma with perceived harms. So in other words, if these behaviors existed at baseline, it predicted substance use 10 years later in girls from that group who experienced teasing about their weight and were bothered by it. So the effect on baseline substance use is small, but it increases over the 10-year interval. So these results also indicate that these unhealthy weight control behaviors at baseline did not predict substance use at 10-year follow-up among girls who did not experience stigma or who experienced weight stigma only. So you had to have that combination of experiencing weight stigma and being bothered by it. So what is the meaningful discussion from this study? The associated harms of weight stigma may be more important in predicting subsequent substance use than the experience of stigma itself. So this finding is consistent with the weight-based social identity threat and functional contextual models, where there is a heightened risk of substance use among individuals who experience the personal harms of weight stigma, as compared to those who do not experience weight stigma and those who experience weight stigma but do not perceive harms associated with it. These findings are also consistent with a commonly accepted theory, which suggests that experiences resulting in negative emotional responses, so weight stigma with perceived harms, are likely to increase the risk of substance use in an attempt to avoid the negative emotional response. So again, using substances to cope with either negative affective states, so such as depression or anxiety, or just feeling stigma related to the teasing that you're experienced. So what were the conclusions that they drew from this study? That helping adolescents develop healthy alternative coping strategies to the weight stigma they experience may be helpful in preventing future substance use in vulnerable girls and women. So very interesting and significant study. So now let's discuss the screenings for eating disorders. So there are several screenings available for eating disorders. So first, let's talk about the United States Preventive Services Task Force recommendation regarding screening for eating disorders. This came out in March of 2022. For asymptomatic adolescents and adults, current evidence is insufficient to assess the balance and harms of screening for eating disorders in adolescents and adults. For adolescents 10 years and older and adults, the evidence is insufficient to assess the balance and harms of screening for eating disorders, anorexia nervosa, bulimia nervosa, and binge eating disorder in particular in adolescents and adults. Having said that, let's talk about what the screenings are for eating disorders. So as I mentioned, there are several available. The first is the Yale Food Addiction Scale, followed by the Eating Disorder Diagnostic Scale, followed by the Eating Disorder Examination Questionnaire. There is also the SCOFF questionnaire. So the SCOFF questionnaire is a screening tool for eating disorders with 1 point awarded for every positive reply and a score greater than 2, indicating likely anorexia nervosa or bulimia nervosa. So do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you lost more than 1 stone in a 3-month period? Stone is a measurement of weight that is used in the United Kingdom, and 1 stone is approximately 14 pounds or 6.35 kilograms. Do you believe yourself to be fat when others say you are too thin? Would you say that food dominates your life? So now I'm going to move into specific eating disorders. So first, we're going to discuss binge eating disorder. So what are the DSM-5 criteria for a binge eating disorder diagnosis? To be diagnosed with binge eating disorder, a person must have episodes of binge eating at least once a week for 3 months. And during these episodes, the person will feel a lack of control over their eating. They can't stop eating or control how much or when they eat. The episodes occur within a discrete time period, and that would be 2 hours. Binge eating episodes cannot occur exclusively during the course of anorexia nervosa or bulimia nervosa. Repeated attempts to stop binge eating or repeated attempts at dieting do not exclude someone from a binge eating disorder diagnosis. Binge eating episodes are associated with 3 or more of the following symptoms: eating much more quickly than normal, eating until uncomfortably full, eating large amounts of food even when not physically hungry, eating alone because of embarrassment about how much one is eating, feeling disgusted with oneself, depressed, or very guilty afterward. A major distinction between binge eating disorder and bulimia nervosa is that there are no recurrent behaviors used to avoid weight gain or compensate for binge eating. These are known as compensatory behaviors, and these behaviors may include things such as purging or making yourself vomit or extreme restriction of food intake. So, similar to substance use disorders, binge eating disorders are graded on a continuum of severity. An individual has mild binge eating disorder if they have 1 to 3 binge eating episodes per week. They have a moderate binge eating disorder if they have 4 to 7 binge eating episodes per week. They have a severe binge eating disorder if they have 8 to 13 binge eating episodes per week. And they have extreme binge eating disorder if they have 14 or more binge eating episodes per week. So, what is the crux of binge eating disorder? So, some of the key concepts or terms that we can associate with binge eating disorder are all in, struggling with boundaries, people pleasing, passive, codependency, and shame. What is the epidemiology of binge eating disorder? So, binge eating disorder is the most common eating disorder and is more common than anorexia nervosa and bulimia nervosa. A nationally representative face to face US household survey of nearly 10,000 respondents determined that about 2.3% of females and 0.8% of males will develop binge eating disorder. Approximately 40% of those with binge eating disorder are male, and binge eating disorder often begins in the late teens or early 20s, but it has been reported in young children as well as older adults. Binge eating disorder is sometimes mischaracterized as a food addiction, which is not a recognized psychiatric disorder. And while many people with binge eating disorder are overweight, binge eating disorder can also occur in people who are normal weight. As most people who are overweight or have obesity do not have binge eating disorder, it is important not to conflate obesity with binge eating disorder. Approximately 30% of the, 36% of the individuals with binge eating disorder have been obese in their lifetime, and 23 to 46% of obese individuals have binge eating disorder. While most people may think of binge eating disorder as a less serious disorder than anorexia nervosa or bulimia nervosa, it can be severe, debilitating, and even life-threatening. What are some potential symptoms of binge eating disorder? So, as we've mentioned, binge eating disorder is a condition where people lose control over their eating and they have recurring episodes of eating unusually large amounts of food. Unlike bulimia nervosa, periods of binge eating are not followed by purging, excessive exercise, or fasting to compensate for the overeating. So as a result, people with binge eating disorder often are overweight or obese. And as mentioned, it is the most common eating disorder in the United States. So symptoms can include eating unusually large amounts of food in a specific amount of time. We mentioned that 2-hour time period. Eating even when you're full or not hungry. Eating very fast during binge episodes. Eating even when you're full. Eating alone or in secret to avoid embarrassment, feeling distressed, ashamed, or guilty about your eating, frequently dieting, possibly without weight loss, and having a negative mood and cognitive rigidity to cope with negative emotionality. What are some of the recommended treatments for binge eating disorder? So, first line treatment for binge eating disorder in adults is individual psychological therapy. And while there are a number of approaches that might be used depending on an individual's situation and needs, some of the most common approaches include the following: cognitive behavioral therapy for binge eating disorder. So, manual based cognitive behavioral therapy, or CBT, is the most researched psychotherapy for binge eating disorder, and it's the best supported among the treatment options. It is a time limited approach that focuses on the interaction between thoughts, feelings, and behaviors. So, some key components of CBT include psychoeducation, mindfulness, self monitoring of key behaviors, cognitive restructuring, and establishing regular patterns of eating. CBT for binge eating disorder addresses dietary restriction and the incorporation of feared foods. It also tackles thoughts about shape and weight and offers alternative skills for coping with and tolerating distress. Lastly, CBT teaches people strategies to prevent a return to binge eating disorder behaviors. So it's extremely important when working with individuals with eating disorders to remember that the goal of CBT is about behavioral change. It is not about weight loss. So when used for treating binge eating disorder, CBT doesn't necessarily lead to weight loss. So, the next therapy I'm going to discuss briefly is interpersonal therapy. So, this is a short term treatment that focuses on interpersonal issues and uses dialectical behavioral therapy, or DBT, a form of CBT designed to address impulsive behaviors. So, these therapies are also supported by research for treating binge eating disorder. So, research does suggest that people who have binge eating disorder tend to have more interpersonal problems, which can contribute to their feelings of psychological distress. And often these interpersonal problems leading to psychological distress predate the onset of the eating disorder, but they often contribute to it as well. So it shows promise in the treatment of binge eating disorder. Only one study that I reviewed found it less effective than CBT. And then, very briefly, there are other psychotherapies that can be used to treat binge eating disorder. So they have been studied, they do show some promise, but there are too few studies to make a definitive conclusion that they are effective for treating binge eating disorder. So mindfulness-based eating awareness training, or MBEAT, blends mindful eating with mindfulness strategies, and it does show some promise. So it utilizes mindfulness practices to help people become more aware of hunger cues and alter eating behaviors to avoid binge eating. There's also family therapy and group therapy, which may be good options for some individuals with binge eating disorder. But again, there's not enough research to evaluate their efficacy, specifically with binge eating disorder. What about medication treatment for binge eating disorder? So antidepressants, primarily SSRIs or selective serotonin reuptake inhibitors, have been shown to be helpful in clinical trials in reducing the frequency of binges or with eating-related obsessions or thoughts about food. Antidepressants also will reduce comorbid depressive symptoms. Specifically, Vyvanse, which is the name brand, the generic name is lisdexamfetamine, an ADHD medication, has become the first medication to be approved by the FDA for the treatment of binge eating disorder. It was studied in 3 trials and was associated with reductions in binge episodes per week, decreased eating-related obsessions and compulsions, and reductions in weight. Anticonvulsant medications, particularly topiramate, which has several name brands, have also been studied, and there is some limited evidence to suggest it is useful in treating binge eating disorder. And while the research on Vyvanse and FDA approval for the treatment of binge eating disorder is definitely promising, all medications carry a potential risk of adverse side effects that are not found by utilizing psychotherapy alone for the treatment of binge eating disorder. What about self-help and guided self-help? So, in a 2015 review study, researchers noted that the number of therapists with expertise in CBT for binge eating disorder is limited. So, given that there's such a large number of afflicted individuals with the diagnosis of binge eating disorder, the limitation of trained therapists definitely poses a challenge. One strategy to bridge that treatment gap has been the development of self-help and guided self-help treatments for binge eating disorder, which again shows some promise. What about nutritional counseling for binge eating disorder? Professional counseling can help people learn more about nutrition and can be helpful in treating binge eating disorder. But because many people with binge eating disorder also have a history of trying to lose weight, the counseling should not be focused on weight loss until the eating disorder itself has been treated. So, nutritional counseling in general can help people learn healthier eating habits. They can learn about essential nutrients and, just generally speaking, just learn how to eat in a more healthy fashion. It can also help establish eating habits that will help people avoid binge eating behaviors. And then lastly, we should talk about concerns about weight loss treatments. So because a significant percentage of people who have binge eating disorder also have obesity, people with binge eating disorder have historically sought treatment for and been treated for weight loss. Some earlier studies seem to show that behavioral weight loss might be effective for the treatment of binge eating disorders, but many of these studies were small and poorly designed. A 2010 study found that behavioral weight loss was inferior to CBT in reducing binge eating and also did not result in significant weight loss. The study researchers concluded that effective methods for producing longer-term weight loss remain elusive. Many eating disorder professionals believe that attempts at weight loss among patients with binge eating disorder may only exacerbate the problem and further entrench the disorder, causing intense shame and resulting in weight gain. While CBT and behavior change tend to result in weight loss, the main focus of these treatments is not on losing weight. So there was a systematic review of international clinical guidelines for the treatment of binge eating disorder, and I'm going to go through the summaries of those that systematic review of the international clinical guidelines. So the current systematic review sought to compare available evidence-based clinical treatment guidelines for all specific eating disorders. So for binge eating disorder, the first-line treatment per several international guidelines recommend outpatient treatment as the first-line treatment setting for binge eating disorder. And some of those countries that recommended it included Germany, the Netherlands, and the United Kingdom. With respect to hospitalization, criteria for hospitalization for binge eating disorder were provided by 4 guidelines, including Australia, New Zealand, Germany, the Netherlands, and the United Kingdom. With respect to nutritional counseling, an explicit recommendation for nutritional counseling was made by the guideline from the United States, specifically within the context of behavioral weight loss programs. The Spanish guideline generally recommended nutritional counseling for patients with eating disorders, generally speaking, not specific to binge eating disorder, with a psychiatrist's approval. With respect to psychological interventions, all the guidelines provided recommendations for specific psychological interventions except one, the World Federation of Societies of Biological Psychiatry. CBT was consistently recommended by all 6 guidelines, followed by guided or unguided cognitive behavioral self-help treatment and interpersonal psychotherapy. An explicit recommendation for psychodynamic therapy was made only by the German guideline. With respect to first-line psychotherapy, 4 guidelines recommended CBT, with 1 guideline favoring guided cognitive behavioral self-help treatment, which was the United Kingdom. With respect to treatment format, guidelines varied significantly. 1 guideline specifically recommended individual psychotherapy, 1 prioritized group format, and 2 guidelines did not include any preference, which included the United States guidelines. Family-based treatment was recommended for children and adolescents with binge eating disorder only by the Dutch guideline. What about with respect to pharmacotherapy? The use of antidepressants was generally recommended by 3 guidelines, including the United States. These 3 guidelines and 3 other guidelines consistently made a specific recommendation in favor of SSRIs for reducing binge eating episodes, at least in the short term. For TCAs, or tricyclic antidepressants, only 1 guideline recommended their use. Specifically, they recommended imipramine. For anticonvulsants, 3 guidelines, including the United States, consistently recommended the use of topiramate, while the remaining guidelines did not report on it. Consistently, two out of 2 guidelines reporting on anti-obesity medications explicitly recommended their use, specifically orlistat, for weight loss in patients with binge eating disorder and comorbid obesity. In addition to weight loss, the anti-obesity medication sibutramine was recommended for reducing binge eating, and that was recommended by the United States, and 2 guidelines explicitly made a recommendation for pharmacological treatment in conjunction with psychological therapies, and that included the United States. With respect to the treatment of comorbidities, 3 guidelines reported on the treatment of comorbidities, and 2 guidelines made recommendations for the medical management of binge eating disorder. Next, we're going to discuss anorexia nervosa. First, let's go over the DSM-5 criteria for an anorexia nervosa diagnosis. An intense fear of gaining weight. People with anorexia nervosa typically fear weight gain and dread becoming fat, and fat is in quotes, because many individuals were not overweight to begin with. This fear often manifests itself through depriving the body of food intake restriction. People with anorexia nervosa tend to eat less food than the body needs to function correctly. This may lead to significantly low body weight for the person's age and height. A distorted body image. This has to do with the person's own perception of their body size. People with anorexia nervosa often have exaggerated views of their bodies. They generally view themselves as overweight, even if they're dangerously underweight. There are subtypes of anorexia nervosa, 2 subtypes specifically, the restricting type and the binge eating purging type. With respect to the restricting type of anorexia nervosa, people with this type place severe restrictions on the amount and type of food they eat. Restrictive behaviors include counting calories, skipping meals, or eliminating certain foods, such as carbohydrates. These behaviors are sometimes coupled with excessive exercise. The second subtype is the binge eating and/or purging subtype. With this subtype, they also restrict their food intake, but in addition, they also regularly engage in binge eating or purging behaviors, or both, such as self-induced vomiting or misuse of laxatives or diuretics. Anorexia nervosa is also graded for severity on a continuum. Mild anorexia nervosa, individuals have a BMI of greater than 17. Individuals with moderate anorexia nervosa have a BMI between 16 and 16.99. Severe anorexia nervosa individuals have a BMI of 15 to 15.9, and individuals with extreme anorexia nervosa have a BMI less than 15. So what is the crux of anorexia nervosa, or what are some key concepts or words that we can use to describe individuals with anorexia nervosa? It has to do with restriction. So think isolation, withdrawal, struggling to ask for or receive help, passive, distant, aloof, avoidance, and guarded. What is the epidemiology of anorexia nervosa? So typically it begins in adolescence or in children 15 years or younger. The condition primarily affects girls and women. However, like all other eating disorders, anorexia nervosa can affect people of all ages, genders, and racial ethnic backgrounds. Worldwide, it's estimated that up to 4% of females experience anorexia nervosa and 0.3% of males. People with anorexia nervosa may display specific behavioral symptoms like refusing to eat in front of others, over-exercising to burn calories, or hiding their bodies in loose-fitting clothing. Some people also develop food rituals like cutting food into tiny pieces, rearranging food on the plate to make it look like they've eaten more than they actually have. Serious medical complications are associated with anorexia nervosa. For example, it can cause malnutrition, low blood pressure, slowed breathing and pulse, and damage to the heart and heart function. It can also cause severe dehydration and electrolyte imbalances, and in some cases, these symptoms can be life-threatening, particularly with electrolyte imbalances and heart arrhythmias. One of the most harmful misconceptions about anorexia nervosa is that all people who struggle with it are severely underweight. While this is true for some, many people with anorexia nervosa can appear to be in good health when in actuality they are malnourished. Anorexia nervosa also has a term associated with it called atypical anorexia nervosa, and this is used to describe anorexia nervosa in people who aren't underweight. What are some potential symptoms of anorexia nervosa? So obviously not all of these symptoms will be indicative of anorexia nervosa. Some people may display all of the symptoms, some people may not display any of them, but symptoms can include being underweight, sometimes severely so, binging and purging by vomiting or taking laxatives, constipation, bloating, and stomach pain, dehydration, distorted body image, dizzy spells and faintness, extreme tiredness or fatigue, extremely restrictive eating, intense fear of gaining weight, loss of periods in women or failure to begin a menstrual cycle in girls, loss or fluctuation of body fat and muscle, poor circulation, constantly feeling cold, skin that is yellow, dry, or covered in soft hair, which is called lanugo, taking diet pills or other diet aids, talking about weight or food all the time, and suicidal thoughts or actions. What are some anorexia nervosa health consequences? So besides the symptoms listed on the previous slide, other symptoms can develop over time with anorexia nervosa. These include thinning of the bones, so leading to osteopenia or osteoporosis, mild anemia and muscle wasting and weakness, brittle hair and nails, severe constipation, low blood pressure, again, slowed breathing and pulse, damage to the structure and function of the heart, brain damage, multi-organ failure, drop in internal body temperature, causing again a person to feel cold all the time, and infertility. And anorexia nervosa can be fatal. So it actually has an extremely high mortality or death rate compared with other mental health diagnoses. People with anorexia nervosa are at risk of dying from medical complications associated with starvation. And suicide is the second leading cause of death for people diagnosed with anorexia nervosa. What are some recommended treatments for anorexia nervosa? So this was a systematic review and network meta-analysis. 13 randomized controlled trials were included in this meta-analysis. There were over 1,000 patients. The vast majority of them were female. What were the primary outcomes that they were looking at? They were looking at change in BMI or body mass index and clinical symptoms. Their secondary outcome was an all-cause dropout rate. What were the treatments that were assessed? Treatment as usual, cognitive behavioral therapy, Maudsley anorexia treatment for adults, or MANTRA, family-based treatment, psychodynamic-oriented psychotherapies, a form of CBT targeting compulsive exercise, and cognitive remediation followed by CBT. What were the findings? None of the interventions outperformed treatment as usual for the primary outcomes, but the all-cause dropout rate was lower for CBT than for psychodynamic-oriented psychotherapies. So what's the interpretation of this systematic review? Compared with treatment as usual, specific psychological treatments for adult patients with anorexia nervosa can be associated with modest improvements in terms of clinical course and quality of life, but no reliable evidence supports clear superiority or inferiority of the specific treatments that are recommended by clinical guidelines internationally. So obviously that's extremely disappointing. And this was published in the Lancet a psychiatry journal in March of 2021. So this is reviewing the same systematic review of international clinical guidelines that I reviewed for binge eating disorder, but we're going to look at those for the treatment of anorexia nervosa. So it, again, is comparing available evidence-based clinical treatment guidelines from around the world for specific eating disorders. So what is the first-line treatment for anorexia nervosa? All guidelines recommended outpatient treatment as a first-line therapy setting for patients with anorexia nervosa. What about hospitalization? For determining more intense levels of care, most guidelines did provide criteria for partial or full-time hospitalization. But the degree of detail that the guidelines provided and the range of hospital criteria that they included were highly variable between different countries. So the guidelines did consistently emphasize the necessity to decide about hospitalization on an individual basis, taking multiple factors into account. Overall, hospitalization should be considered for patients who have failed at outpatient care or who are at high risk for medical complications as determined using the patient's weight status. So for example, if someone had an extremely low body mass index, they were going to be at higher risk for medical complications. If they have particular behavioral factors, such as a decline in oral intake, they have unstable vital signs, such as a heart rate less than 40 beats per minute, or they have significant psychiatric comorbidity, such as they are a risk for suicide, or there are environmental aspects that are hindering the individual stabilizing, such as family support or lack thereof. What about recommendations for compulsory treatment? For very malnourished patients who do not consent to treatment, most guidelines provided some information on compulsory treatment. Criteria for discharge from the hospital were specified by the majority of guidelines, and they emphasized the importance to treat patients with anorexia nervosa and eating disorders in generally by specialized professionals or individuals who have substantial experience in the treatment of eating disorders. So this is very wordy, and I'm not going to go into the detail of this because this is very detailed. However, there were recommendations from some guidelines, most of them actually, around nutritional management. So they ranged in detail from going through details of artificial feeding to general nutritional counseling. So the information provided on artificial feeding differed among the guidelines as far as the mechanism of refeeding, the duration of artificial feeding, and the specific indication for artificial feeding. Most guidelines did favor the individuals were fed orally as opposed to parenteral or IV nutrition. And really, the IV nutrition should be a last option. Some of the guidelines did did recommend general nutritional counseling, but other guidelines recommended a more multidisciplinary therapy approach, that nutritional counseling should not stand alone as a type of treatment. Some guidelines got into specific about the amount of calories that people should be fed daily. Some got into specific guidelines around nutritional supplementation, etc. So the point is that there was no uniformity of nutritional management for anorexia nervosa. What about recommendations for psychotherapy? So all of the guidelines recommended psychotherapy as a central part of treatment for anorexia nervosa. But recommending specific psychological interventions was more variable between the guidelines. So all of the guidelines recommended family-based therapy for younger patients with anorexia nervosa. With respect to individual psychotherapy, CBT was often recommended as the first-line type of psychotherapy. There was less agreement between guidelines about psychodynamic therapy and interpersonal psychotherapy. And with respect to any of the other types of treatment that I mentioned on an earlier slide, they were not mentioned in the international guidelines. So again, there's not a clear recommendation other than family-based therapy for younger patients, and generally speaking, CBT as recommended as first-line therapy. But as I shared with you a few slides back, in looking at a systematic review of studies on anorexia nervosa, CBT looked like people remained in care longer when they got CBT as opposed to other types of therapy, but there was no clear benefit to CBT over other types of therapy with respect to concrete outcomes in anorexia nervosa. What about pharmacotherapy? So many of the guidelines did make some recommendations around pharmacotherapy. So two guidelines recommended that actually medication not be used as the sole or primary treatment for patients with anorexia nervosa. Some guidelines generally recommended pharmacotherapy, but did not recommend a specific medication. Most of the guidelines did say that antidepressants were generally recommended for depressive symptoms in individuals with anorexia nervosa. But one guideline in particular cautioned against the use of antidepressants for weight gain. With respect to SSRIs, some recommended using it for its treatment of depressive symptoms in conjunction with psychotherapy, but only after weight restoration. That was from the United States guideline. And others made general recommendations against their use, particularly in children and adolescents. With respect to tricyclic antidepressants, these were pretty much not favored in the guidelines, though there was one recommendation specifically against using them, which was the United States, and one cautious recommendation in favor of using them, and that was France. The use of monoamine oxidase inhibitors, or MAOIs, and specifically the medication bupropion, which is an atypical antidepressant, were not recommended by the United States guideline. And that was the only guideline that specifically singled out those medications as being not recommended. Some guidelines cautiously recommended using antipsychotics for treating obsessional thinking in patients with anorexia nervosa, and particularly refer to olanzapine. So there were conflicting results in trials with antipsychotics around success in treating anorexia nervosa, and also conflicting evidence with respect to weight gain with antipsychotics. Promotility agents, again, causing rapid transit within the gastrointestinal tract, and anti-anxiety agents were only recommended by the guideline from the United States for treating gastrointestinal problems and to reduce anticipatory anxiety concerning food intake. The use of lithium was not recommended by the German guideline, and 4 guidelines stated that estrogen should not be offered to patients with anorexia nervosa. With respect to adjunctive treatments, recommendations were not commonly made in the guidelines, but when they were made, included meal support, eating training, supervised physical activity, physical therapies such as electroconvulsive therapy and transcranial magnetic stimulation were not recommended by 2 of the guidelines, and 4 of the guidelines included information on the medical management of anorexia nervosa, and 3 guidelines additionally added recommendation regarding pregnancy and pregnancy attempts with anorexia nervosa. With respect to the treatment of comorbidities, 2 guidelines specifically provided information about the treatment of both physical and mental comorbidities, as well as artificial feeding, including refeeding syndrome. This was a study that looked at the time course of return to anorexia nervosa behaviors after acute treatment for anorexia nervosa. So this study looked at individuals who were in an inpatient program in an acute care setting for weight restoration. So they followed 93 women with anorexia nervosa who were randomized to receive fluoxetine, medication therapy, or placebo, and then were discharged from that inpatient acute care setting to outpatient care, where they received cognitive behavioral therapy for up to 1 year. So they defined relapse as a return to symptoms prior to their inpatient treatment. So fluoxetine did not have an impact on the time to return to anorexia nervosa symptoms. And what they found was that the highest risk period for return to symptoms was after more than 60 days after discharge from the inpatient setting, up to 90 days. So essentially, that's a highly vulnerable period of time for individuals after they've been discharged from an inpatient setting. So what they encouraged was close follow-up and monitoring in the outpatient setting after an inpatient setting for anorexia nervosa, particularly up to 3 months after their discharge, to reinforce not returning to symptoms of anorexia nervosa. What about experimental treatment for anorexia nervosa? So this was a study that looked at ketamine infusions for anorexia nervosa. So this was its use was first reported in a case series on patients with non-responder anorexia nervosa in the late 1990s. And again, these were very small case series. So there were 15 patients in this series, and they had complex chronic histories of anorexia nervosa. 4 people had comorbid compulsive eating, 5 people had comorbid bulimia, and 30% had restrictive subtype of anorexia nervosa. And the ketamine infusion showed prolonged symptom remission after 2 to 9 intramuscular ketamine infusions at intervals of 5 to 21 days. There was also another small case series in 4 patients who were chronically ill with anorexia nervosa. They had intramuscular ketamine infusions every 4 to 6 weeks with improvement in depression, anxiety, and anorexia nervosa symptoms. There's a single case report of a woman with chronic severe anorexia nervosa, intermittent active alcohol use disorder, and depression who with ketamine infusions had a complete recovery with also a ketogenic diet in addition to the ketamine infusions. So the mechanism of action suspected by the authors of these case series was a glutamatergic neurotransmission plays an important role, particularly in anorexia nervosa. And so NDMA modulation and MDMA antagonists as a mechanism of action may be helpful in treatment of anorexia nervosa. So next I'll discuss bulimia nervosa. So first, let's go over the DSM-5 criteria for a bulimia nervosa diagnosis. All of the following criteria must be met for a bulimia nervosa diagnosis. Repeated episodes of binge eating, defined as eating an amount of food that is definitely larger than most people would eat during the same amount of time. A loss of control. The person must feel as though they have lost control of overeating and are unable to stop themselves or control how much they are eating. use of inappropriate behaviors, which are known as compensatory behaviors, to avoid weight gain or to compensate for the binge eating. These include self-induced vomiting, likely the best known of these compensatory behaviors, the misuse of laxatives, diuretics, and/or enemas, and excessive exercise. Both the binge eating and compensatory behaviors occur at least once a week for 3 months. The person's weight and/or body shape must have a significant impact on the way the person views him or herself. Individuals with anorexia nervosa may display these behaviors as well. People who meet these criteria only during episodes of anorexia nervosa are not considered bulimic. They are also categorized on a severity continuum. Individuals with mild bulimia nervosa have an average of 1 to 3 episodes of inappropriate compensatory behaviors per week. Individuals with a diagnosis of moderate bulimia nervosa have an average of 4 to 7 episodes per week. And individuals with a severe bulimia nervosa diagnosis have an average of 8 to 13 episodes per week. And finally, individuals with extreme bulimia nervosa have an average of 14 or more compensatory behavior episodes per week. When we think about the crux of bulimia nervosa and words that we associate with bulimia nervosa, think of purging, unexpressed emotional pain, push-pull or struggle with congruence, passive-aggressive / aggressive, punishment of self and others, and shame. So there are many potential symptoms of bulimia nervosa. Let's go over some of the potential physical symptoms. So dentists are often the first to notice signs of self-induced vomiting in persons with bulimia nervosa because there's a telltale pattern of dental erosion that's primarily on the internal surface of the teeth. So it's not visualized externally, for example, when someone smiles. But oral health concerns obviously are not the only physical symptom linked to bulimia nervosa. People may also experience bloodshot eyes, calluses on the back of the hand, chest pains, chronic bouts of constipation resulting from laxative misuse, electrolyte imbalances and dehydration, frequent sore throat, headache, heart palpitations, lightheadedness or loss of balance. They may experience fainting, mouth ulcers, stomach aches, swelling of hands and feet, swollen glands and roundness in the jaw area, tooth cavities, tooth sensitivity, vomiting blood, yellowing, graying, spotted, or decaying teeth. Puffy cheeks among people who purge or vomit is one of the most noticeable physical signs. Calluses on the hand occur from people inserting their fingers in their mouth to cause vomiting, and they may be visible, and this is called Russell's sign. And later in the illness of bulimia nervosa, the sign may not be visible as the person may not even need to use mechanical stimulation in order to vomit. There are also many behavioral symptoms potentially associated with bulimia nervosa, and these include some of the following symptoms, and these are often noticed by family members and friends of the individual with bulimia nervosa. Creation of schedules or rituals that allow for binging and purging, desperation to exercise even when it gets in the way of other activities, evidence of binge eating, including stashing food, stealing food, and eating large amounts in one sitting, evidence of purging, such as always needing to go to the restroom immediately after eating, or showering immediately after eating, or carrying packages of laxatives or diuretics, exercising a specific amount to burn off the calories that have been taken in, extreme eating habits, so strict dieting followed by overeating, a fatigued experience, a fatigued appearance, frequent trips to the bathroom, large amounts of food that are missing from cabinets or the pantry, large amounts of food packaging in trash cans or vehicles, frequently talks about dieting, calories, food, or weight, so much that it actually interferes with regular conversations, uses medications or substances or detox teas as a way to suppress appetite, and withdraws from family, friends, and usual activities. What are some of the emotional symptoms that are associated with bulimia nervosa? So Obviously, it can be more difficult to notice emotional symptoms than necessarily behavioral symptoms, but frequently emotional symptoms are recognized by family members and friends, even if they're unaware of the individual's binging and purging behaviors. So the emotional issues are not unique to bulimia nervosa, but some of these emotional symptoms may cause concern for individuals, family and friends of individuals who could be bulimic. Depression, extreme irritability, extremely self-critical, feeling out of control, mood swings, self-esteem, self-worth, or attractiveness determined by appearance and weight, and a strong need for approval. What's some of the epidemiology of bulimia nervosa? So, as many as 2 to 3% of women may have bulimia nervosa in the United States, and in some vulnerable populations, so think college-aged women, the estimate could be as high as 10% of that specific population may meet the diagnostic criteria for bulimia nervosa. Men are affected too, but at about 1/10 the rate of women with bulimia nervosa. Young women may be especially prone to bulimia nervosa if they have experienced childhood sexual abuse, if they eat alone, if they live in a sorority house, or if they have low self-esteem. Involvement in athletics or employment in a job that focuses on weight, like modeling or acting or dancing, can predispose someone to bulimia nervosa. Gay men also have a high rate of bulimia nervosa compared to heterosexual men. So, going back to that systematic review of the international guidelines, what does it look like for the treatment of bulimia nervosa? So, first line treatment, all guidelines recommended outpatient therapy as the first line treatment for bulimia nervosa. What about hospitalization? Multiple guidelines provided criteria for partial and full time hospitalization. What about nutritional counseling? It's generally recommended by the Danish guideline, either in an individualized format or a standardized format. Two other guidelines emphasize that nutritional interventions, for example, to help develop a structured meal plan, should not be offered as standalone therapy. And the United States was included in that recommendation. What about psychological interventions? Other than one guideline, all of the available guidelines did issue recommendations on specific psychological interventions. Five guidelines recommended CBT as the first line psychotherapy for patients with bulimia nervosa, particularly in an individual format. Other two guidelines made recommendations in favor of cognitive behavioral interventions, but prioritize cognitive behavioral guided self-help treatment as first line treatment, or did not provide an explicit treatment hierarchy. Overall, many recommended self-help approaches, such as guided self-help based on cognitive behavioral interventions, or structured self-help manuals, supplemented with brief supportive sessions with a therapist. Interpersonal psychotherapy was recommended as an alternative to CBT by most of the guidelines, while psychodynamic therapy was rarely recommended. Family-based therapy was recommended for younger patients with bulimia nervosa and only explicitly recommended for adults by the United States guideline. The German guideline recommended CBT for children and adolescents with bulimia nervosa and emphasized the importance of including the patient's family in the treatment for the individual with bulimia nervosa. And alternative psychological interventions, such as the combination of psychodynamic therapy and CBT, couples therapy, and support groups were also recommended. What about pharmacotherapy? So most of the guidelines consistently recommended antidepressants, specifically the SSRI fluoxetine, though with some restrictions. So for example, I put a reference there that people can go to see what one specific guideline recommended about combinations of therapies to use with antidepressants. So there were conflicting recommendations for the use of TCAs such as imipramine and dizipramine, and the US guidelines specifically did not recommend TCAs for initial treatment in patients with bulimia nervosa. Guidelines consistently recommended against the use of MAOIs. The United States was included in that group, and the use of anticonvulsants, specifically topiramate, was recommended by 2 of the guidelines, while the remaining guidelines did not report at all on anticonvulsants. The only guideline which made a recommendation about lithium cautioned against its use, that was the United States guideline. And for patients with comorbid obesity, one guideline recommended the anti-obesity medication orlistat. With respect to treatment of comorbidities, 4 guidelines included specific information about the treatment of comorbidities, and 3 guidelines made recommendations for the medical management of bulimia nervosa. What about other types of feeding or eating disorders? So there are several categories of other types of feeding or eating disorders. So the DSM-5 included 2 other forms of eating disorder: other specified feeding or eating disorders and eating disorder not otherwise specified, which had previously been grouped together in the DSM-4-TR as eating disorder not otherwise specified, or EDNOS. So in the current DSM-5, let's go over the definition of the term OSFED, or other specified feeding or eating disorder. This term is more specific and applies primarily to people with some or most of the symptoms of anorexia nervosa, bulimia nervosa, or binge eating disorder, but aren't experiencing symptoms frequently enough or haven't been experiencing symptoms long enough to qualify for a full diagnosis. It also includes purging disorder, which occurs when someone uses purging behaviors but does not engage in binge eating disorders as in bulimia nervosa. To meet criteria for OSFED, a person must present with clinically significant distress and impairment, but do not meet the full criteria of any of the other eating disorders. Another example of OSFED is when someone meets the criteria for binge eating disorder, but engages in binging behaviors at a lower frequency or for a limited period of time. Eating disorder not otherwise specified, or EDNOS, this broader category encompasses problems that don't fit into any current category or when the diagnosing professional doesn't have enough information. So, for example, a provider in the emergency room. Avoidant restrictive food intake disorder, or RFED, was previously known as selective eating disorder and is a condition where people limit the amount or type of food eaten. Unlike anorexia nervosa, people with RFID do not have a distorted body image or extreme fear of gaining weight. RFID is most common in middle childhood and usually has an earlier onset than other eating disorders. Many children go through phases of picky eating, but a child with RFID does not eat enough calories to grow and develop properly, and an adult with RFID does not eat enough calories to maintain basic body function. Symptoms include dramatic restriction of types or amount of food eaten, lack of appetite or interest in food, dramatic weight loss, upset stomach, abdominal pain, or other gastrointestinal issues with no other known cause, limited range of preferred foods that becomes even more limited, so picky eating that gets progressively worse. I'm going to move on and discuss co-occurring eating disorders and substance use. So let's look at co-occurring disorders and substance use. On the left-hand side is looking at the prevalence of substance use disorders among those with eating disorders. So in those with anorexia nervosa, the prevalence is 12 to 18%. In those with binge eating disorder, the prevalence is 25%. And in those with bulimia nervosa, the prevalence is anywhere between 30 to 50%. According to the National Center on Addiction and Substance Use, 50% of individuals with eating disorders have misused alcohol or illicit drugs. This is 5% higher than the general, 5 times higher than the general population, where it's about 10% of the general population that has a substance use disorder. This is looking, again, still at co-occurring eating disorders and substance use disorder. On the left-hand side is looking at that there are more mental health comorbidities in persons with eating disorders especially those with bulimia nervosa or anorexia nervosa, binge purging type, and substance use disorder. So again, these would include individuals most commonly with major depressive disorder or with panic disorder or with obsessive compulsive disorder or post-traumatic stress disorder. Those are the most common diagnoses. And the most recommended therapy for individuals with these comorbidities would be DBT. We also see less emotional regulation, less goal-directed activity, and increased impulsivity in persons with eating disorders and substance use disorder. And this probably also has to do with the fact that they also have comorbid mental health diagnoses, particularly those associated with impulsivity, such as bipolar disorder. So substance use issues may begin before or during an eating disorder, or even after recovery from an eating disorder. Those who have co-occurring substance use and disordered eating should seek care with a professional who knows how to treat both disorders. Up to 50% of individuals, as I mentioned on the previous slide, with eating disorders use alcohol or illicit substances. So that's a rate 5 times higher than the general population. Up to 30% of individuals who have a substance use disorder also have an eating disorder, which is a rate 11 times greater than the general population. Substances most frequently used by individuals with eating disorders or with subclinical symptoms of eating disorders include alcohol, laxatives, emetics, diuretics, amphetamines, heroin, and cocaine. I would imagine the numbers would be similar for fentanyl, but this data came before the current epidemic with fentanyl and its analogs. Eating disorders and substance use also share a common number of risk factors, as I mentioned when we went over risk factors for eating disorders. These include changes to brain chemistry, family history, low self-esteem, depression, anxiety, social pressures. Other shared characteristics include compulsive behavior, social isolation, and risk for suicide. Males with binge eating disorder are 2 times more likely to have a substance use disorder compared to females, yet higher rates of specific substance use disorders, such as cocaine, use of psychotherapeutics, medications, and alcohol use disorder have higher rates among females. So this slide is looking at some of the genetic effects that occur in individuals that have comorbid eating disorders and substance use disorder. And it's a complex interplay of factors. So there are genetic factors, there are epigenetic factors, and there are environmental factors. So on the right-hand side, they were looking at twin studies to try to get heritability estimates for eating disorders. So they're very high for eating disorders. They range between 28 to 74% for anorexia nervosa, 28 to 83% for bulimia nervosa, and 39 to 45% for binge eating disorder. And then obviously other environmental factors contribute to the remaining variance between those individuals in those studies. So there is definitely a lot of evidence from family, twin, and adoption studies that indicates, the average number given is that about 50% of the variation in substance use disorder heritability is attributable to additive genetic factors. Again, that ranges by substance. So for individuals with cocaine use disorder, that heritability may be closer to 80%. So what about eating disorders, looking at a community-based sample of women with alcohol use disorder and nicotine dependence or tobacco use disorder? So what this found was that women with comorbid alcohol use disorder and tobacco use disorder had a higher prevalence of eating disorder symptoms and diagnoses than women who had either alcohol use disorder or tobacco use disorder alone. So they had a higher prevalence than those that did not have either substance use disorder. So again, it's recognizing that there's sort of a confluence of effects when people have comorbid diagnoses, particularly comorbid substance use disorders, mental health diagnoses, and an eating disorder diagnosis. So in this study, the conclusion was that women with lifetime alcohol use disorder or tobacco use disorder diagnoses are at high risk for eating disorder symptoms and diagnoses. So again, underscoring the importance of assessing eating disorder symptoms among women with substance use disorder. What about co-occurring eating disorders and mental health diagnoses? And at the bottom, I just put something to think about. So maladaptive interpersonal experiences. How does your relationship with food mimic your relationship with self and others? So this is looking at data between eating disorders and co-occurring mental health diagnosis. On the left-hand side, in a nationally representative sample of respondents with eating disorders, the following percentages met the criteria for one or more co-occurring disorders. Respondents with anorexia nervosa, 56%. Respondents with binge eating disorder, 79%. Respondents with bulimia nervosa, 95%. So 64% of respondents with bulimia nervosa fit the criteria for 3 or more mental health diagnoses. What about eating disorders and common other co-occurring disorders, specifically looking at obsessive compulsive disorder? So there's a very elevated risk for obsessive compulsive disorder among those with eating disorders. So 69% of patients with anorexia nervosa have a diagnosis of OCD, and 33% of patients with bulimia nervosa have a diagnosis of OCD. So, what about eating disorders and predisposition to stress? So, much evidence does suggest that eating disorder patients may be particularly sensitive or vulnerable to stress and its consequences. So, individuals with anorexia nervosa or bulimia nervosa more often than not have a primary anxiety disorder. So, in other words, the anxiety disorder preceded the onset of their eating disorder. In addition, research indicates that individuals with eating disorders are more likely to perceive threat or hostile intent from others, exhibit high levels of anxiety sensitivity, so a fear of behaviors or sensations associated with anxiety, and this is characterized by fear or of loss of control, are often over-concerned or preoccupied with negative consequences, have exaggerated inhibition, self-restraint, and the inability to act in a relaxed way, and anticipatory anxiety or tension over an expected negative outcome, are sensitive to punishment and have difficulty adapting to change, and have weak central coherence, so have difficulty seeing the big picture and get hung up on often trivial details. What about eating disorders and PTSD? So there's a common a connection between eating disorders and PTSD. So one of these important connections is having traumatic or adverse experiences and the development of eating disorders and other mental health diagnoses, such as the presence of PTSD after that experience. So as we know, PTSD tends to be a chronic condition, especially when it's not treated or addressed. And so, a study that was done nationally saw that over 1/3 of individuals with an index episode of PTSD still had the full spectrum of the syndrome 10 years later. So, like many individuals with PTSD, it is not uncommon for eating disorder patients with PTSD who tend to have more comorbidities and more complicated courses do not get adequate assessment and treatment for their PTSD. So, unresolved trauma and or PTSD can be an important preceding factor to development of eating disorders, but also in the maintenance of symptoms of that eating disorder diagnosis. So, two major national representative studies showed that individuals with bulimia nervosa, binge eating disorder, or any binge eating have significantly higher rates of PTSD than individuals without an eating disorder. In that same study, the National Comorbidity Study, and also in the National Women's Study, the highest rates of lifetime PTSD were 38% and 44% in those two studies, respectively, in the bulimia nervosa groups. When partial or subclinical forms of PTSD are also considered, then well over half of the individuals with bulimic symptoms have PTSD or significant PTSD symptoms. Traumatized people with eating disorders demonstrate high levels of dissociative symptoms, such as amnesia of traumatic material, so being unable to remember the traumatic event in detail, which are often also factors that contribute to a negative medical outcome. Continuing with the theme of binge eating, purging, and trauma, so in much the same way misuse of certain substances is used to self-medicate, binge eating and or purging appear to be behaviors that facilitate reducing the hyperarousal or anxiety associated with trauma. They help numb, avoid, or even forget the traumatic experience, and these behaviors are reinforcing, making it difficult to break the cycle. So as a result, traumatic experiences and their destructive effects are not effectively processed and continue to cause problems. In this way, trauma, PTSD, and eating disorders can be very much intertwined. What about treatment for individuals who have comorbid eating disorders, PTSD, and trauma? So the treatment requires that you treat all the conditions simultaneously using a trauma-informed integrated approach. If the trauma is not addressed during the treatment of an eating disorder, it is likely that successful recovery will be thwarted. So important factors that contribute to the success of treatment can include positive reactions by family members and close friends to disclosure about traumatic events, as well as strong support from family and friends. The best approach to address PTSD in the context of an eating disorder does remain elusive. Likely, the focus will remain on cognitive processing therapy, integrated with traditional treatment for the eating disorder as the most efficacious form of treatment. But likely, we will see, hopefully, future research that can give us the best treatment combination. Next, I'm going to talk about identity and eating disorders. So eating disorders, as I've mentioned several times, historically have been associated with the sort of straight, young, white female. But in reality, they affect people from all demographics and are not caused by any single factor. So as mentioned previously, they arise from a combination of longstanding behavioral, biological, emotional, psychological, interpersonal, and social factors. Misconceptions about who eating disorder affects have real consequences, so they lead to fewer diagnoses, treatment options, and pathways to help those who don't fit that stereotype. Understanding that eating disorders don't discriminate is critical to making sure everyone has access to help and support. And when it comes to identity and eating disorders, one's experience should be understood within the broader cultural context of oppression. So there are many, many groups that may be affected by eating disorders and have specific identity associated with those groups. I'm going to go through some of these populations. So athletes. So athletics are a great way to build self-esteem and physical conditioning and demonstrate teamwork, but not all stressors associated with athletics are positive. There's often an overemphasis on body weight and shape. The disability community. So people with disabilities experience unique stressors that may contribute to the development of eating disorders. There's definitely a lack of research around looking at individuals with disabilities and disordered eating. So we don't even know how disproportionately the eating disorders impact different segments of the disability community. The Jewish community. So again, eating disorders do not discriminate. And there have been several studies that have showed a rise in eating disorders among the Jewish community, from the less religious Jews to the ultra-Orthodox Jews. And eating disorders in the Jewish community look similar to eating disorders in the secular world, but what differs is the effect that culture has on the eating disorder and in the treatment that's recommended for recovery from eating disorder. The LGBTQ plus population. So again, the LGBTQ plus population experience unique stressors that may contribute to the development of eating disorders. And there's still a lot of research that needs to be done on the relationships between sexuality, gender identity, body image, and eating disorders to know how they disproportionately impact the LGBTQ plus community. Men and boys, again, because there is a misconception that eating disorders only affect women, men have been discouraged from coming forward about their experiences with eating disorders. So this may lead to diagnosis or undiagnosed eating disorders. And there's also a social stigma around males with eating disorders seeking help for their eating disorder. Those that are aged midlife and beyond, there's no age limit on disordered eating. And again, despite stereotypes, eating disorders can develop later in life. So unfortunately, we have a rise of eating disorders and body dissatisfaction among older populations, and we need to increase our awareness on the best modality of treatment for these populations, as well as recognizing it in these populations. People of color. So again, eating disorders have historically been associated with heterosexual young white females, but affect people from all races and ethnicities at similar rates. People of color, especially African Americans, are significantly less likely to receive help for their eating disorder issues. Size diversity and health at every size. Eating disorders can affect people of all different sizes and shapes, and you can't tell by looking at someone if they have an eating disorder. So there are genetic factors that play into that, that influence bone structure, body size, shape, and weight differently. And again, we want to encourage healthy eating and healthy behaviors in all persons and treat all persons, regardless of size and shape, with respect. Let's briefly talk about the COVID-19 pandemic's impact on eating disorders. So the COVID-19 pandemic has exacerbated the burden of eating disorders. There have been multiple reports from different countries in Europe, Australia, and North America that have shown an increase in eating disorders or diagnoses in the community or deterioration of eating disorder behaviors in patient populations, often with more severe symptoms and comorbidities since the start of the COVID-19 pandemic. Using an electronic health record of 5.2 million young people, the overall incidence of eating disorders increased during the COVID-19 pandemic by 15.3% in 2020 compared with previous years. The increase occurred solely in women and girls and was primarily observed in adolescents and for anorexia nervosa. Now we'll go over types of psychotherapy for eating disorder treatment. So first, let's just talk about the different types of psychotherapy. So one of the important considerations when selecting who is going to do psychotherapy with a patient with eating disorder is understanding exactly what type of therapy they provide. So obviously there are different types of therapy that have different efficacy with treating individuals with eating disorders, but different therapies in general will work differently for different people. So it's important that we understand where someone is at in their eating disorder journey. So that may be dependent on helping us decide which type of therapy would be best for them. So as we've discussed earlier in this presentation, it's important that the focus of the therapy being on reducing eating disorder behaviors or reducing disordered eating behaviors. That should really be what the goal of treatment is, as opposed to thinking about something like losing weight for someone who may be obese and have binge eating disorder. But again, we discussed that in more detail in those individual sections previously. So I'm going to very briefly go through these types of psychotherapy. I am not a psychotherapist, I'm a physician, so I do not have extensive knowledge about these different types of therapy. So we're going to keep the descriptions of these pretty brief. So the first therapy, these are all listed in alphabetical order, is acceptance and commitment therapy, or ACT. The focus of ACT is to change your actions rather than your thoughts and feelings. So people are taught to identify core values and commit to creating goals that fulfill these values. It also encourages patients to detach themselves from emotions and learn that pain and anxiety are a normal part of life. So the goal isn't to feel good, but to live a more authentic life. And through living a good life, people often find that they can start to feel better. The next therapy is cognitive behavioral therapy, or CBT, and enhanced cognitive behavioral therapy, or CBTE. So these are designed to be short-term, symptom-oriented therapies that focus on beliefs, values, and cognitive processes that maintain the eating disorder behavior. What the goal of CBT and CBTE therapies are to modify distorted beliefs and attitudes about the meaning of weight, shape, and appearance, which are correlated to the development and maintenance of an eating disorder. So let's talk a little bit about evidence-based treatment and what that means. So I think it's important that everyone understand that many therapies are used frequently, all different kinds of therapies to treat individuals with eating disorders, and they have varying levels of efficacy and research that support their use, as we discussed earlier. So when we say we recommend evidence-based treatment, what that means is that we want to focus on providing the patient with conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So as I discussed previously, with respect to therapy in eating disorders, we really don't have much definitive evidence for some of the eating disorders on what the best evidence-based treatment is with respect to therapy. So I shared some results from some research studies previously, but again, other than CBT likely being the most effective for example, bulimia nervosa, we don't necessarily know what is the most effective type of therapy for other eating disorders. What we do want to make sure we focus on in therapy, though, is reducing the eating disorder symptoms. So the symptoms that are causing distress, the symptoms that are leading a person to be more dysfunctional with respect to their eating in their life. For individuals specifically who are underweight, most typically we're talking about individuals with anorexia nervosa, we want to encourage weight restoration and again, decrease those eating disordered thoughts. So it's challenging to classify a specific therapy as evidence-based for an individual, because we know that different types of therapy are going to work well for different types of people, and not everything works for everyone. Just because something might be evidence-based and successful in a clinical trial doesn't mean it will be successful for that patient that you're working with. So it's important when we're providing recommendations for our patients with eating disorders that we do some research and try to target treatments which will target the symptoms and psychological concerns of that individual. It's also important to know that sometimes when therapists advertise for their practice, they may not specify the type of treatment or the type of therapy that they use. So it's important to ask questions of the therapist to determine what type of therapy they offer. So next is family-based treatment, or FBT. This is also known as the Maudsley method or the Maudsley approach. And this is a home-based treatment approach that has been shown to be effective for adolescents with anorexia nervosa and bulimia nervosa. FBT does not focus on the cause of the eating disorder, but instead places focus on refeeding, at least initially, to get particularly significantly underweight individuals back to a normal body mass index, and full weight restoration to promote recovery. So particularly with adolescent patients, all family members are considered an essential part of treatment. And this consists of reestablishing healthy eating, restoring weight, and interrupting any compensatory behaviors if those are happening. And that could be either with bulimia nervosa or with anorexia nervosa, binging, purging subtype, and restoring control of eating back to the adolescent and focusing on any other remaining issues that may be going on within the family dynamic. The next is interpersonal psychotherapy, or IPT. So this is an evidence-based treatment for bulimia nervosa and binge eating disorder. And IPT contextualizes eating disorder symptoms as occurring and being maintained within a social and interpersonal context. IPT is associated with specific tasks and strategies linked to the resolution of a specified interpersonal problem area. The 4 problem areas include grief, interpersonal role disputes, role transitions, and interpersonal deficits. IPT helps clients improve relationships and communication and resolve interpersonal issues in the identified problem areas. And then in turn, that would result, hopefully, in the reduction of eating disorder symptoms. Just as interpersonal dysfunction is linked to the onset and maintenance of eating disorder behaviors, healthy relationships and improvements in interpersonal functioning usually are linked with symptom reduction. The next is psychodynamic psychotherapy. In this approach, it holds that recovery from an eating disorder requires understanding of its root cause. Psychodynamic psychotherapists view behaviors as the result of internal conflicts, motives, and unconscious forces. And if behaviors are discontinued without addressing the underlying motives that are driving them, then a resumption of those behaviors would recur. So symptoms are viewed as expressions of the patient's underlying needs and issues and are thought to be resolved with the completion of working through those issues. I'm going to talk briefly about the prevention of eating disorders. So I guess the first question to ask is, does eating disorders prevention work? So there are many studies that have evaluated a variety of eating disorders and disordered eating prevention programs, and some of the major findings are as follows. So general findings: prevention programs can alter knowledge, attitudes, and behaviors associated with eating disorders and disordered eating. Various programs have successfully discouraged the development of eating problems in children, adolescents, and young adults. But clearly there is much more research that is needed concerning prevention and appropriate prevention techniques for the prevention of eating disorders. So we definitely lack information about prevention programs that work, say, best with children or with males or with people from a variety of different racial and ethnic groups. So what are some findings on program types? Universal, selective, and indicated or targeted prevention programs have had some success, though targeted programs may have had more success. Universal prevention is often difficult to research due to its focus on large-scale policy and normative attitudinal changes. There is good evidence that targeted programs using a social learning theory, cognitive behavioral, media literacy, and cognitive dissonance approaches are effective with adolescents and young adult women from various ethnic groups. The cognitive dissonance approach encourages girls and women to question the media and cultural messages by asking them to speak out against the appearance ideal and other eating disorder risk factors through verbal, written, and behavioral exercises. The conflict between one's beliefs and actions creates psychological discomfort, motivating the individual to change their beliefs to match their actions. Programs that have also shown some success include, but are not limited to, those that adopt an ecological approach involving not only individual change, but also changing the environment of teacher and peer behavior media and literacy programs, and programs that emphasize health. Specifically, we're going to look at the evidence for the BODY project. So the BODY project is backed by 2 decades of research and evaluation data. It is a group-based intervention that provides a forum for women and girls excuse me, to confront unrealistic beauty ideals and engages them in the development of a healthy body image through verbal, written, and behavioral exercises. Research has shown that women and girls talk about the, quote, appearance ideal, unquote. Sometimes we also refer to this as the thin ideal, the beauty ideal, or the cultural ideal. That's typically portrayed in the mass media and discuss how to challenge pressures to conform to these pressures to make them feel better about their bodies. The BODY project was developed by researchers at Stanford University, the University of Texas at Austin, and the Oregon Research Institute, and has been delivered to over 1 million young women around the world. And this is just commenting, this is an image from the BODY project of the effect of media on women's body image. So now I'm going to focus on evidence-based treatment for eating disorders in general. So first, what are some of the health consequences of eating disorders? And we've discussed some of these previously, but we're going to revisit it here. So if we look at the most prevalent eating disorders in the United States, anorexia nervosa, bulimia nervosa, and binge eating disorder, what are some of the effects of those? So first, let's think about comorbid mental health conditions. It often consists of affective disorders, which include depression and bipolar disorder, as well as anxiety, suicidality, particularly associated with anorexia nervosa, and sleep disturbances. There is a component of malnutrition that can be overnutrition from overeating, and it can be undernutrition from starving oneself or restricting intake. Undernutrition has multiple complications, including a lack of nutrients, dehydration, and specific deficiencies, specific vitamins, minerals, and iron. And then that, either overnutrition or undernutrition, leads to physical health consequences such as GI tract issues, endocrine and metabolic issues, cardiovascular issues, osteoporosis or bone thinning, pain, and skin issues. So when we talk about evidence-based treatment for eating disorders, what does that look like? So again, we're speaking generally here about the evidence-based treatment for eating disorders, not about specific eating disorders. So to reiterate, evidence-based treatments are interventions or therapies that are supported by published research demonstrating effectiveness. This constitutes the evidence. So these are treatments that have been well tested, compared against other established treatments, and then trying to identify what types of therapies or interventions give us the best outcomes. So what do we need to know as far as evidence-based treatment for treating eating disorders? So again, we'll focus on anorexia nervosa, bulimia nervosa, and binge eating disorder best practices because those are the 3 most prevalent eating disorders in the United States. So in this particular study that I reviewed, there was an exhaustive review of the most current treatments for feeding and eating disorders. As we've mentioned, the 3 big ones in adults and adolescents, and I'm going to go over the highlights. So in the majority of clinical trials, enhanced cognitive behavioral therapy, CBTE, has been shown to be the most effective treatment for adult anorexia nervosa, bulimia nervosa, and binge eating disorder. Enhanced CBTE was designed specifically for eating disorders. So as I mentioned previously, it's very structured and time-limited treatment. It has 3 distinct phases. The primary focus of the treatment, regardless of which eating disorder we're talking about, is to establish a regular pattern of stable, flexible eating and to address the different factors, things that people put extreme focus on, such as shape and weight or mood-related eating, that keep the eating disorder going. There's broad agreement that whenever possible, patients should be treated in the least restrictive setting. So as we mentioned previously, according to international guidelines on treating eating disorders, that would be in the outpatient setting for all eating disorders, at least to start. So more restrictive settings like hospitals and residential treatment centers are only for those with the most severe symptoms or medical complications. Day treatment programs, partial hospitalization programs, and intensive outpatient programs are more intensive and structured settings if the individual is not progressing in standard outpatient care. For those who are medically stable and able to participate in outpatient treatment, it would be in their best interest to do so. For children and adolescents with anorexia nervosa or bulimia nervosa, they should be treated with family-based treatment or the Maudsley method. Research studies have consistently shown that family-based treatment is the best treatment for children and adolescents with anorexia nervosa, and an emerging body of evidence is showing similar effectiveness for children and adolescents with bulimia nervosa. The beauty of FBT, or family-based therapy, is not only that it's so effective, but it's also time efficient. So it requires once weekly meetings, it's cost effective, so it's much cheaper than intensive residential or other inpatient programs, and it's delivered in a real life setting because it occurs in the individual's home. According to a recent paper in the American Journal of Psychotherapy, there's good evidence to support the use of DBT skills training with adult patients with bulimia nervosa and binge eating disorder. The evidence, as I mentioned when we did the section on anorexia nervosa, is less compelling but encouraging. There's promising evidence to support the use of DBT with any eating disorder patient who also has borderline personality disorder. And in one study, about 20% of patients with eating disorders have comorbid borderline personality disorder. Given the effectiveness of DBT with borderline personality disorder, it makes sense that DBT would be effective for this subpopulation who's dually diagnosed. So for pharmacological treatment for eating disorders, to recap, for anorexia nervosa, there are no FDA-approved medications for the treatment of anorexia nervosa. Potentially promising medications include olanzapine, aripiprazole, dronabinol, and D-cycloserine. For bulimia nervosa, fluoxetine is FDA approved for the treatment of bulimia nervosa. Off-label medications include topiramate, amitriptyline, imipramine, fluvoxamine, and trazodone. Bupropion is contraindicated in bulimia nervosa, and ondansetron is not recommended due to QTc prolongation or an effect in the heart rhythm. Binge eating disorder, lisdexamfetamine is FDA approved for the treatment of binge eating disorder. SSRIs, including citalopram, fluvoxamine, fluoxetine, and sertraline, are off-label use for binge eating disorder. Topiramate and topiramate with phentermine are off-label use for binge eating disorder, and atomoxetine is used off-label for binge eating disorder. So what can we do to help, and what does recovery look like with respect to eating disorders? So what can we do about eating disorders, and what can we do to prevent eating disorders? We should be using neutral language around food. We also want to change the way that we approach body talk. So that means we should not be commenting, including complimenting people on their weight or their shape. We want to affirm and reinforce character traits like kindness and curiosity that are not related to somebody's weight or body shape. We want to be inclusive and celebrate diversity. And we want to address unmet emotional needs in relation to ourselves and others. What does full recovery look like for someone with an eating disorder? First, it entails effective coping and intuitive eating. So tolerating spontaneous natural eating and a wide variety of foods. There's an absence of purging, restricting, and binge eating behaviors. And it's recognizing signs of disordered thinking and seeking appropriate help when it occurs. There's body acceptance, maintaining caloric and nutrient intake that supports a healthy body weight, not obsessing about food, exercise, or body image. And it's developing a healthy identity, having a strong sense of self and one's values, and developing healthy attachments. So I'm going to spend the rest of the presentation talking about additional statistics and research on eating disorders in various subpopulations. So first, to summarize some statistics and research on anorexia nervosa. So at any given point in time, between 0.3 and 0.4% of young women and 0.1% of young men will experience anorexia nervosa. More recent studies in the US have used broader definitions of eating disorders that more accurately reflect the range of disorders that occur, which has resulted in a higher prevalence of eating disorders. In a 2007 study of almost 10,000 English-speaking Americans about a variety of mental health conditions, including eating disorders, the following were the results. 0.9% of women and 0.3% of men had anorexia nervosa during their lives. In another study, researchers followed a group of almost 500 adolescent girls for 8 years until they were 20 years old and found that 5.2% of the girls met criteria for DSM-5 criteria for anorexia nervosa, bulimia nervosa, or binge eating disorder. And when researchers included non-specific eating disorder symptoms, a total of 13.2% of the girls had had a DSM-5 eating disorder by age 20. So combining information from several sources, in 2012, researchers found that between 0.9 and 2% of females and 0.1 and 0.3% of females will develop anorexia nervosa. Again, if we include a broader range of criteria for subthreshold anorexia nervosa, it occurs in 1.1 to 3% of adolescent females. Young people between the ages of 15 and 24 with anorexia nervosa have 10 times the risk of dying compared to their same aged peers. Males represent 25% of the individuals with anorexia nervosa and are at a higher risk of dying, in part because they're often diagnosed later, since people do not associate males with eating disorders, particularly anorexia nervosa. Subclinical eating disordered behaviors, so including binge eating, purging, laxative misuse, and fasting for weight loss, are nearly as common among males as they are among females. There's an ongoing study in Minnesota that has found the incidence of anorexia nervosa increasing over the last 50 years only in females aged 15 to 24. Incidence remained stable in other age groups and in males. What about statistics and research on ARFID? In a group of adolescents with eating disorders receiving treatment at a specialist clinic, 14% met criteria for ARFID. Those with ARFID are more likely to be younger and male. Many children with ARFID reported the following symptoms: food avoidance, decreased appetite, abdominal pain, and emetophobia, or the fear of vomiting. Half of children with ARFID report fear of vomiting or choking, and 1/5 say they avoid certain foods because of sensory issues. The same study found that 1/3 of children with ARFID have a mood disorder, and 3/4 have an anxiety disorder, and nearly 20% have an autism spectrum condition. How about statistics and research on athletes? In a study of Division I NCAA athletes, over 1/3 of female athletes reported attitudes and symptoms placing them at risk for anorexia nervosa. Though most athletes with eating disorders are female, male athletes are also at risk, especially those competing in sports that tend to emphasize diet, appearance, size, and weight. In weight class sports, which include wrestling, rowing, and horse racing, and aesthetic sports such as bodybuilding, gymnastics, swimming, and diving, about 1/3 of male athletes are affected. In female athletes in weight class and aesthetic sports, disordered eating occurs up to 62% of the time. Among female high school athletes in aesthetic sports, over 41% reported disordered eating. They were 8 times more likely to incur an injury than athletes in aesthetic sports who did not report disordered eating. One study found that 35% of female and 10% of male college athletes were at risk for anorexia nervosa, and 58% of female and 38% of male college athletes were at risk for bulimia nervosa. Prevalence of eating disorders in college athletes is higher among dancers and the most elite college athletes, particularly those who are involved in sports that emphasize a lean physique or weight reduction, like figure skating, wrestling, and rowing. Among female college athletes surveyed, over 25% had subclinical eating disorder symptoms. In a survey of athletic trainers working with female collegiate athletes, only 27% felt confident identifying an athlete with an eating disorder. Despite this, 91% of athletic trainers reported dealing with an athlete with an eating disorder. 93% of trainers felt that increased attention needs to be paid to preventing eating disorders among collegiate female athletes. And 25% worked at an institution without a policy on managing eating disorders. A study of female Division II college athletes found that 25% had disordered eating, 26% reported menstrual dysfunction, 10% had low bone mineral density, and 2.6% had all three symptoms. Female high school athletes reporting disordered eating were twice as likely to incur a musculoskeletal injury as athletes who did not report disordered eating. What about statistics and research on binge eating disorder? So one organization, the National Eating Disorder Organization, or NEDA, gathered data on the prevalence of eating disorders from the US, the UK, and Europe to get a better idea of exactly how common eating disorders are. Though binge eating disorder is not a new disorder, its new formal recognition by the research community has left more gaps with respect to its incidence and prevalence than we see for anorexia nervosa and bulimia nervosa. In the same 2007 study of over 9,000 English-speaking Americans about mental health conditions, including eating disorders, they found that 3.5% of women and 2% of men had binge eating disorder during their lifetime. So that makes binge eating disorder more than 3 times more common than anorexia nervosa and bulimia nervosa combined. Binge eating disorder is more common than breast cancer, HIV, and schizophrenia. When researchers followed that same group of almost 500 adolescent girls for 8 years until they were 20 years old, as mentioned on the previous slide, they found that over 5% of those girls met criteria for one of the big 3 eating disorders. And when they used more non-specific eating disorder symptoms, over 13% met criteria by age 20. Combining that information from several sources, researchers found that 0.2 to 3.5% of females and 0.9 to 2% of males will develop binge eating disorder, and subthreshold binge eating disorder occurs in 1.6% of adolescent females. Research also estimates that about 29% of people with current binge eating disorder are receiving treatment for their disorder, and over 43% of people with binge eating disorder at some point in their lives will receive treatment. Binge eating disorder often begins in the late teens or early 20s, although it has been reported in young children and in older adults. Approximately 40% of those with binge eating disorder are male, and 3 out of 10 individuals looking for weight loss treatment show signs of binge eating disorder. How about statistics and research on bulimia nervosa? So using that same database, looking at eating disorders in the US, UK, and Europe, at any given point in time, 1% of young women and 0.1% of young men will meet diagnostic criteria for bulimia nervosa. In that 2007 study with the over 9,000 English-speaking Americans, they found that 1.5% of women and 0.5% of men had bulimia nervosa during their lifetime. And I've already shared the last statistic on the global effect and percentages of eating disorders. So combining information from several sources, they concluded that between 1.1 and 4.6% of females and 0.1 and 0.5% of males will develop bulimia nervosa, and subthreshold bulimia nervosa occurs in 2% to 5.4% of adolescent females. It isn't clear if these numbers have changed over time. It appears that at least for the last 2 decades, the rates of new diagnoses of anorexia nervosa and bulimia nervosa have remained relatively stable, though I did present earlier in the presentation some data during COVID-19 that showed that particularly rates of anorexia nervosa are increasing. There was a Dutch study that was published a few years ago that found that new diagnoses of anorexia nervosa and bulimia nervosa remained relatively stable during 2 time periods in the Netherlands, from 1985 to 1989 and from 1995 to 1999. Rates of bulimia nervosa increased during the 80s and early 90s, but they have remained stable or decreased slightly since then. A British study also found stability in new anorexia nervosa and bulimia nervosa diagnoses in both males and females, though they saw that rates of EDNOS diagnoses increased in both groups. And eating disorder symptoms are beginning earlier in both males and females, which has been confirmed in both research and clinical reports. What about statistics and research on bullying and weight shaming? So the best known environmental contributor to the development of eating disorders is the socio-cultural idealization of thinness. By age 6, girls especially start to express concerns about their own weight or shape. 40 to 60% of elementary school girls, so ages 6 to 12 years old, are concerned about their weight or about becoming too fat, and this concern endures through life. 79% of weight loss program participants reported coping with weight stigma by eating more food. Of American elementary school girls who read magazines, 69% say that the pictures influence their concept of the ideal body shape. 47% say the pictures make them want to lose weight. Up to 40% of overweight girls and 37% of overweight boys are teased about their weight by peers or family members. Weight teasing predicts weight gain, binge eating, and extreme weight control measures. And as we saw in one study, whose results I presented earlier, it can also lead to substance use 10 years later. Weight-based victimization among overweight youths has been linked to lower levels of physical activity, negative attitudes about sports, and lower participation in physical activity among overweight students. Among overweight and obese adults, those who experience weight-based stigmatization engage in more frequent binge eating, are at increased risk for eating disorder symptoms, and are more likely to have a diagnosis of a binge eating disorder. Children of mothers who are overly concerned about their weight are at increased risk for modeling their unhealthy attitudes and behaviors. Weight stigma poses a significant threat to psychological and physical health. It has been documented as a significant risk factor for depression, low self-esteem, and body dissatisfaction. Low self-esteem is a common characteristic of individuals who have eating disorders. Perceived weight discrimination is significantly associated with a current diagnosis of mood and anxiety disorders and mental health services use. What about statistics and research on co-occurring disorders? So 2/3 of people with anorexia nervosa also show signs of an anxiety disorder starting before the onset of their eating disorder. Childhood obsessive compulsive traits such as perfectionism, having to follow the rules, and concern about mistakes were much more common in women who developed eating disorders than in women who didn't develop eating disorders. In a study of more than 2,400 individuals hospitalized for an eating disorder, they found that 97% had one or more co-occurring conditions, including 94% had co-occurring mood disorders, mostly major depression. 56% were diagnosed with anxiety disorders. Of those anxiety disorders, 20% had an obsessive compulsive disorder, 22% had post-traumatic stress disorder, and 22% had either an alcohol use disorder or another substance use disorder. Approximately 1 in 4 people with an eating disorder has symptoms of PTSD, and in women hospitalized for an eating disorder, almost 37% regularly self-harmed. A 2009 study that was published found that 1 in 5 women seeking treatment for an eating disorder had 6 or more signs of attention deficit hyperactivity disorder, or ADHD. Personality disorders also commonly occur in individuals with eating disorders. Among those with anorexia nervosa, with respect to restricting type, 20% had obsessive compulsive personality disorder and 10% had borderline personality disorder. With respect to anorexia nervosa binge purge type subtype, 12% had obsessive compulsive personality disorder and 25% had borderline personality disorder. Among those with bulimia nervosa, 11% had obsessive compulsive personality disorder and 28% had borderline personality disorder. In a 2014 study that looked at data from 20 previous studies, they found personality disorders in 38% of people with EDNOS-OSFED. Of those, 11% had obsessive compulsive personality disorder and 12% had borderline personality disorder. 30% of people with binge eating disorder had personality disorders, and of those, 10% had obsessive compulsive personality disorder and 10% had borderline personality disorder. Depression and other mood disorders co-occur with eating disorders very frequently. There's a markedly elevated risk for obsessive compulsive disorder among those with eating disorders. One study found that almost 74% of patients with binge eating disorder had at least one additional lifetime psychiatric disorder, and over 43% had at least one current psychiatric disorder. Among lifetime disorders, mood, anxiety, and substance use disorders were most common. Among current comorbidities, mood disorder and anxiety disorder were the most common. Up to 69% of patients with anorexia nervosa and 33% of patients with bulimia nervosa have a coexisting diagnosis of obsessive compulsive disorder. Binge eating disorder patients with co-occurring psychiatric disorders also had significantly higher levels of current eating disorder psychopathology, negative affect, and lower self-esteem than patients with binge eating disorder without a co-occurring condition. And certain psychiatric disorders, particularly obsessive compulsive disorder, mood disorders, and personality disorders, are frequently found among those with eating disorders. That's a wide range of estimates, anywhere from 42 to 75%. In a nationally representative survey, 95% of respondents with bulimia nervosa, 79% of respondents with binge eating disorder, and 56% of respondents with anorexia nervosa met criteria for at least one other psychiatric disorder. 64% of those with bulimia nervosa met criteria for 3 or more co-occurring psychiatric disorders. In a study of women with eating disorders, 94% of participants had a co-occurring mood disorder, and 92% of those in the sample had a depressive disorder. 32 to 39% of people with anorexia nervosa, 36 to 50% of people with bulimia nervosa, and 33% of people with binge eating disorder were also diagnosed with major depressive disorders. 48 to 51% of people with anorexia nervosa, 54 to 81% of people with bulimia nervosa, and 55 to 65% of people with binge eating disorder are also diagnosed with an anxiety disorder. I recognize that some of the numbers cover a range, and that's because these are gathering research from multiple studies over time. What about statistics and research on compulsive exercise? An estimated 90 to 95% of college students diagnosed with an eating disorder also belong to a fitness facility. An estimated 3% of gym goers have a destructive relationship with exercise. Some studies have found that that number may be even higher, including a 2008 Paris study that found that up to 42% of gym goers have a destructive relationship with exercise. A study involving fitness professionals revealed that 100% of the participants believe that they would benefit from further education and guidelines for identifying and addressing eating disorders. There is a strong link between exercise compulsion and various forms of eating disorders. Between 40 and 80% of anorexia nervosa patients are prone to excessive exercise in their efforts to avoid putting on weight. What about statistics and research on diabulimia? A review of studies published over the last 25 years on the prevalence of eating disorders and insulin restriction among people with diabetes shows that 30 to 35% of women restrict insulin in order to lose weight at some point in their life. This number has remained relatively constant over the decades. A study of adolescents in the year 2000 across 3 Canadian cities found that young women with type 1 diabetes were 2.4 times more likely to have a diagnosable eating disorder and 1.9 times more likely to have a subthreshold eating disorder. More recently, in a study, a third of female patients and a sixth of male patients with type 1 diabetes reported disordered eating and frequent insulin restriction. People with diabetes often experience uncontrolled eating when they experience a low blood sugar. In a Duke University study of almost 300 individuals with type 1 diabetes, the frequency of uninhibited eating contributed to over 31% of insulin omission for weight management. A study of adolescents from Norway revealed that in addition to age, negative attitude toward diabetes and negative beliefs about insulin had the highest association with insulin restriction and eating disorder behavior. People with diabetes also have a higher risk for emotional states, often associated with eating disorders. In an analysis of 42 studies, they found that diabetes doubled the likelihood of having clinical depression. While the majority of studies have been conducted with type 1 diabetes patient population, there is case study and anecdotal evidence that the same prevalence and risk exists in any person with insulin dependence, whether they have type 1 diabetes, type 2 diabetes, or what is known as LADA, latent autoimmune diabetes of adults. How about statistics and research on dieting, healthy eating, and what is called clean eating? In a large study of 14 to 15-year-olds, dieting was the most important predictor of developing an eating disorder. Those who dieted moderately were 5 times more likely to develop an eating disorder, and those who practiced extreme restriction were 18 times more likely to develop an eating disorder than those who did not diet. Over 62% of teenage girls and over 28% of teenage boys report trying to lose weight. Almost 59% of girls and over 28% of boys are actively dieting. Over 68% of girls and 51% of boys exercise with the goal of losing weight or to avoid gaining weight. Over 1/2 of teenage girls and nearly 1/3 of teenage boys use unhealthy weight control behaviors such as skipping meals, fasting, smoking cigarettes, vomiting, and taking laxatives. 35 to 57% of adolescent girls engage in crash dieting, fasting, self-induced vomiting, diet pill use, or use of laxatives. Overweight girls are more likely than normal weight girls to engage in such extreme dieting. Girls who diet frequently are 12 times as likely to binge as girls who don't diet. And even among clearly non-overweight girls, over 1/3 report dieting. 95% of all dieters will regain their lost weight in 1 to 5 years. Over 19% of teenage girls and over 7% of teenage boys fast for 24 hours or more. Over 12% of girls and over 5% of boys use diet pills, powders, or liquids, and over 7% of girls and almost 3% of boys vomit or take laxatives to lose weight or to avoid gaining weight. Over 12% of female high school students took diet pills, powders, or liquids to control their weight without a medical provider's advice. So multiple studies have found that dieting was associated with greater weight gain and increased rates of binge eating in both boys and girls. In elementary school, fewer than 25% of girls diet regularly, yet those who do not know what dieting involves and can talk about calorie restriction and food choices for weight loss fairly effectively. So they may not be actively dieting, but they do have knowledge about how to restrict their calories or how to make different food choices so that they either don't gain weight or that they lose weight. Middle school girls who dieted more than once a week were nearly 4 times as likely to become smokers compared to non-dieters. And a content analysis of weight loss advertising back in 2001 found that more than half of all advertising for weight loss products made use of false and unsubstantiated claims. Americans spend over $60 billion on dieting and diet products every year. What about statistics and research on insurance and legal issues related to eating disorders? So eating disorders are associated with some of the highest levels of medical and social disability of any of the psychiatric diagnoses. In the APA guidelines from 2000 and 1993, they reported the following medical findings. Physical consequences of eating disorders include all serious disorders caused by malnutrition, especially cardiovascular compromise. Prepubertal patients who have arrested sexual maturity and growth failure. Even those who, quote, look and feel deceptively well, unquote, with normal EKGs may have cardiac irregularities, variations with pulse and blood pressure, and are at risk of sudden death. Prolonged amenorrhea, so greater than 6 months at a time, may result in irreversible osteopenia and a high rate of fractures. Abnormal CT scans of the brain are found in greater than 50% of patients with anorexia nervosa. In 1996, Congress passed the Mental Health Parity Act, which is the law that requires plans to provide the same annual and lifetime overall limits for mental health benefits as well as other physical health conditions. Eating disorders ought to receive healthcare coverage and research funding that is equal to that of medical disorders as well as psychiatric conditions that are categorized as serious forms of mental health, but they don't receive equal treatment as far as research dollars. What about statistics and research on the Jewish community? In one study of ultra-Orthodox and Syrian Jewish communities in Brooklyn, 1 out of 19 girls was diagnosed with an eating disorder, which is a rate about 50% higher than the general US population. What about statistics and research on the LGBTQ+ community? Transgender individuals experience eating disorders at rates significantly higher than cisgender individuals. Research is limited in this patient population and conflicting on eating disorders among lesbian and bisexual women. Research does indicate that lesbian women experience less body dissatisfaction overall, and research shows that beginning as early as 12 years old, gay, lesbian, and bisexual teens may be at higher risk of binge eating and purging than heterosexual peers. In one study, gay and bisexual boys reported being significantly more likely to have fasted, vomited, or taken laxatives or diet pills to control their weight in the last 30 days. Gay males were 7 times more likely to report binging and 12 times more likely to report purging than heterosexual males. Females identified as lesbian, bisexual, or mostly heterosexual were about twice as likely to report binge eating at least once per month in the last year. Elevated rates of binge eating and purging by vomiting or laxative misuse were found for both males and females who identified as gay, lesbian, bisexual, or mostly heterosexual in comparison to their heterosexual peers. Compared to other populations, gay men are disproportionately found to have body image disturbances and eating disordered behavior. Gay men are thought to only represent 5% of the total male population, but among men who have eating disorders, 42% identify as gay. In a 2000 study of lesbian, gay, and bisexual identified participants, which was the first study of its kind to use DSM-5 diagnostic categories other than just using looser measures that were indicative of eating disorders, such as eating disorder symptoms in community-based, ethnically and racially diverse populations. Here is what they found. Compared with heterosexual men, gay and bisexual men had a significantly higher prevalence of lifetime full syndrome, bulimia nervosa, subclinical bulimia nervosa, and any subclinical eating disorder. There were no significant differences between heterosexual women and lesbians and bisexual women in the prevalence of any of the eating disorders. Respondents aged 18 to 29 years old were significantly more likely than those aged 30 to 59 years old to have subclinical bulimia nervosa. And Black and Latinx LGB populations have at least as high a prevalence of eating disorders as white LGB populations. A sense of connectedness to the gay community was related to fewer current eating disorders, which suggests that feeling connected to the gay community may have a protective effect against eating disorders. How about statistics and research on other potentially marginalized voices? So despite similar rates of eating disorders among non-Hispanic whites, Hispanics, African Americans, and Asians in the United States, people of color are significantly less likely to receive help for their eating disorder issues. Although eating disorders affect a higher proportion of males who identify as gay or bisexual than females, the majority of males with eating disorders are heterosexual.
15% of gay and bisexual men and 4.6% of heterosexual men had a full or sub-threshold eating disorder at some point in their lives. Black teenagers are 50% more likely than white teenagers to exhibit bulimia nervosa behaviors such as binging and purging. In a study of adolescents, researchers found that Hispanics were significantly more likely to suffer from bulimia nervosa than their non-Hispanic peers. And the researchers also reported a trend towards a higher prevalence of binge eating disorder in all minority groups. From 1999 to 2009, hospitalizations involving eating disorders increased for all age groups, but hospitalizations for patients aged 45 to 65 increased the most by 88%. In 2009, people over the age of 45 accounted for 25% of eating disorder-related hospitalizations. Teenage girls from low-income families are 153% more likely to be bulimic than girls from wealthy families. From 1999 to 2009, the number of men hospitalized for an eating disorder-related cause increased by 53%. A 2014 study found that rates of disordered eating have increased across all demographic sectors, but at a faster rate in male, those lower socioeconomic and older participants. In a study of college students, transgender students were significantly more likely than members of any other group to report an eating disorder diagnosis in the past year. In a study of over 2,800 students at a large university campus, they found that 3.6% of males had positive screenings for eating disorders. The female to male ratio for positive screening was 3-to-1. Subclinical eating disorder behaviors are nearly as common among males as they are among females. There were no significant differences between heterosexual women and lesbians and bisexual women in the prevalence of eating disorders. And when presented with identical case studies demonstrating disordered eating symptoms in white, Hispanic, and African American women, clinicians were asked to identify if the woman's eating this behavior was problematic. 44% identified the white woman's behavior as problematic, 41% identified the Hispanic woman's behavior as problematic, and only 17% identified the Black woman's behavior as problematic. The clinicians were also less likely to recommend that the African American woman should receive professional help. How about statistics and research on media and eating disorders? So according to the Nielsen Company that tracks media habits and trends worldwide, the average American spends more than 11 hours a day using media. So that is more than the average time spent sleeping or working each day. Among American youth aged 8 to 18 years old, media obviously are becoming ever increasingly more involved as part of their daily routine. Teens aged 13 to 18 spend an average of 9 hours per day, and tweens aged 8 to 12 years old average 6 hours per day using entertainment media. And these amounts vary by race, income, and gender, and do not include using media in school or doing homework. Teens and tweens use media for a variety of activities and have different favorites depending on their gender. Boys like to play video games, and girls prefer using social media. According to the Dove Global Beauty and Confidence Report, 10,500 women and girls in 13 countries were surveyed, and they found that beauty and appearance anxiety continue to be critical global issues, and media are a key factor driving their concerns. Approximately 7 in 10 women and girls reported a decline in body confidence, an increase in beauty and appearance anxiety, which they say is driven by the pressure for perfection from media and advertising's unrealistic standard of beauty. Almost 8 in 10 girls, or 79%, and even more women, 85%, admit to opting out of important events in their lives when they don't feel like they look their best. 9 out of 10 women say they will actually not eat and risk putting their health at stake when they feel bad about their body image. And 7 in 10 girls said they're more likely to be less assertive in their decisions when they're feeling insecure. To counteract these unreal messages, a majority of women and girls around the globe are challenging media to portray more diverse physical appearances, age, race, body shapes, and sizes. In a study on social media, nearly all girls, 95%, say they see the onslaught of negative beauty critiques on social media posts, comments, photos, and videos, and a majority see them at least once a week, 72%, and wish social media were a space that empowered body positivity, 62%. According to Common Sense Media, 41% of girls who are teens say the use of social media to make themselves look cooler. Teens feel pressure to look good and cool online, but also feel social media helps their friendships and connections. One study of teen girls found that social media users were significantly more likely than non-social media users to have internalized a drive for thinness and to engage in body surveillance. Another study found social media use is linked to self-objectification, and using social media for merely 30 minutes a day can change the way you view your own body. How about statistics and research on men? From 1999 to 2009, the number of men hospitalized for an eating disorder related cause increased by 53%. The most widely quoted study estimates that males have a lifetime prevalence of 0.3% for anorexia nervosa, 0.5% for bulimia nervosa, and 2% for binge eating disorder. And these figures correspond to males representing 25% of individuals with anorexia nervosa and bulimia nervosa, and 36% of those with binge eating disorder. Those statistics were based on DSM-4 criteria. In a study more recently done of over 1,300 adolescents, the prevalence of any DSM-5 eating disorder diagnosis in males was reported to be 1.2% at 14 years old, 2.6% at 17 years old, and 2.9% at 20 years old. A study of over 2,800 students on a large university campus, I had mentioned this statistic on a previous slide, found that 3.6% of males have positive screens for eating disorder, and the female to male ratio of positive screenings was 3:1. In looking at male sexuality and eating disorders, higher percentages of gay, 15%, than heterosexual males, 5%, had diagnoses of eating disorders, but when these percentages are applied to population figures, the majority of males with eating disorders are heterosexual. Subclinical eating disorder behaviors, including binge eating, purging, laxative misuse, and fasting for weight loss, are nearly as common among males as they are among females. Various studies suggest that the risk of mortality for males with eating disorders is higher than it is for females. Men with eating disorders often have comorbid conditions such as depression, excessive exercise, substance use disorders, and anxiety. A gender-sensitive approach with recognition of different needs and dynamics for males with eating disorders is critical for effective treatment. Males in treatment can often feel out of place when they're predominantly surrounded by females, and it may be that an all-male treatment environment is recommended when possible. How about statistics and research on mortality as related to eating disorders? So eating disorders are serious conditions that can have profound mental and physical impact, including death. So this should not discourage anyone with an eating disorder. Recovery is real. I've stated statistics previously on recovery rates, and treatment is available. Statistics on mortality and eating disorders underscore the impact that these eating disorders can have on individuals and the importance of treatment. Eating disorders have the second highest mortality rate of all mental health disorders, surpassed only by opioid use disorder. Anorexia nervosa has an estimated mortality rate of around 10%. Among those who struggle with anorexia nervosa, 1 in 5 deaths is by suicide. A Swedish study of 6,000 women who were treated for anorexia nervosa found that over 30 years, women with anorexia nervosa had a 6-fold increase in mortality compared to the general population. The researchers also found an increased mortality rate from natural causes such as cancer compared to the general population. Younger age and longer initial hospitalizations were associated with improved outcomes, while comorbid conditions, for example, alcohol use disorder, worsened outcomes. Researchers studied records of over 1,800 individuals evaluated for anorexia nervosa, bulimia nervosa, and EDNOS at the University of Minnesota Outpatient Clinic over 8 to 25 years. They found that there was an increased risk of suicide for all eating disorders studied. Crude mortality rates were 4% for anorexia nervosa, 3.9% for bulimia nervosa, and 5.2% for EDNOS, which is now recognized in the DSM-5 as OSFED. How about statistics and research on PICA? Very limited, but between 4 to 26% of institutionalized individuals are believed to have PICA and an eating disorder. How about statistics and research on substance use and eating disorders? So again, according to the National Center on Addiction and Substance Abuse, please note that I'm using the language that they use, though we would use the term use instead of abuse. Up to 50% of individuals with eating disorders misused alcohol or illicit substances, which is a rate 5 times higher than the general population. Up to 35% of individuals who use substances or had a substance use disorder diagnosis also have had eating disorders, a rate 11 times greater than the general population. The substances most frequently misused, and I had mentioned this earlier when we talked about comorbidities, by those with eating disorders or with subclinical symptoms of eating disorders include caffeine, tobacco, alcohol, laxatives, emetics, diuretics, appetite suppressants, which includes amphetamines, heroin and cocaine. Note that fentanyl and fentanyl analogs are not listed here. However, these studies were done before the onset of the use of illicitly manufactured fentanyl and its analogs. In a study looking at caloric restriction prior to alcohol consumption in college freshmen, 14% of the subjects reported restriction calories, with 6% reporting behavior to avoid weight gain and 10% to enhance alcohol's effect. Women with bulimia nervosa with alcohol use disorder reported a higher rate of suicide attempts, anxiety, personality, and conduct disorders, and other substance use disorders than women with bulimia nervosa without alcohol use disorder. Eating disorders and substance use, as we've discussed previously, share many common risk factors, including changes in brain chemistry, family history, low self-esteem, depression, anxiety, and social pressures. Other shared characteristics include compulsive behavior, social isolation, and risk for suicide. Roughly 20% of men and women being treated for substance use disorders report binge eating, and over 24% of persons with binge eating disorder also have a substance use disorder, and of men with binge eating disorder, over 40% report having a substance use disorder. In a study of women with bulimia nervosa, 44% had a history of alcohol use disorder. 25% of people with anorexia nervosa, 34% of people with bulimia nervosa, and 21% of people with binge eating disorder misuse alcohol or have an alcohol use disorder diagnosis. 27% of people with anorexia nervosa, 37% of people with bulimia nervosa, and 23% of people with binge eating disorder misuse substances or have a substance use disorder diagnosis. How about statistics and research on the comorbidity of trauma, PTSD, and eating disorders? What is traumatic to any given individual is best understood in the light of the 3 E's: the event, the experience, and its effects. Evidence suggests that eating disorder patients may be particularly sensitive or vulnerable to stress and its consequences. PTSD symptoms include re-experiencing symptoms, so flashbacks, nightmares, and intrusive imagery. Hyperarousal symptoms, including irritability or angry outbursts, exaggerated startle reflex, problems concentrating, insomnia, being overly watchful and anxious. Avoidance symptoms, numbing, forgetting, and avoiding trauma-related material, and negative alterations in cognition and mood associated with a traumatic event, beginning or worsening after the traumatic event occurred. So this could manifest as partial amnesia, negative beliefs about oneself, others, or the world, self-blame, constantly expecting the worst. Over 1/3 of individuals with an index episode of PTSD still have the full syndrome 10 years later, and unresolved trauma and/or PTSD can be an important perpetuating factor in the maintenance of symptoms. There have been two major national representative studies that have shown that individuals with bulimia nervosa binge eating disorder or any binge eating have significantly higher rates of PTSD than individuals without an eating disorder. The highest rates of lifetime PTSD were 38% and 44% respectively in the bulimia nervosa groups. When partial or subclinical forms of PTSD are considered, then well over half of individuals with bulimia nervosa symptoms have PTSD or significant PTSD symptoms. In addition, traumatized people with eating disorders demonstrate high levels of dissociative symptoms, such as amnesia of traumatic material, so they're unable to remember the traumatic event, which are also factors that contribute to a negative medical outcome. When partial or subclinical forms of PTSD are considered, then well over half of individuals with bulimia nervosa do have PTSD or significant PTSD symptoms. In much the same way misuse of certain substances is used to self-medicate, binge eating and or purging appear to be behaviors that facilitate reducing hyperarousal or anxiety associated with trauma and the numbing, avoidance, or even forgetting of traumatic experiences. So because it helps with those hyperarousal or anxiety symptoms and it facilitates numbing and avoidance, these behaviors then become reinforcing. So it makes it difficult for individuals to break the cycle of disordered eating. So as a result, traumatic experiences and their destructive effects are not effectively processed and continue to cause problems for the individual. Individuals with an eating disorder complicated by trauma and PTSD require treatment for both conditions using a trauma-informed and integrated approach. Although the best approach to address PTSD in the context of an eating disorder remains unclear, most of the research has focused on using cognitive processing theory integrated with traditional treatment for the combination treatment of PTSD and the eating disorder. So we still need research to understand best how to treat these comorbidities. Unresolved trauma and or post-traumatic stress disorder can be an important perpetuating factor in the maintenance of eating disorder symptoms. As I mentioned on the earlier slide, once these behaviors set in, then it's very difficult to break the cycle. Individuals with these comorbidities of one of the more predominant eating disorders, such as bulimia nervosa binge eating disorder or any binge eating disorders, often have significant rates of lifetime PTSD. We've talked about some of these, so I'm just going to focus on the points that I haven't made previously. So women who have survived assault were almost 2 times more likely to develop bulimia nervosa than those who had not experienced assault. So 26% versus 13.3%. And according to one study, rates of sexual violence were up to 48% of females and 68% of males with anorexia nervosa, and up to 41% of females and 24% of males with bulimia nervosa, and up to 35% of females and 16% of males with binge eating disorders. So let's wrap it up with some conclusions on eating disorders and substance use. So eating disorders can affect people of all ages, racial and ethnic backgrounds, body weights, and genders. Binge eating disorder is the most common eating disorder. Childhood sexual abuse, trauma, and weight stigma, teasing, and bullying contribute to the development of eating disorders. Substance use and substance use disorder are common in persons with eating disorders. Bulimia nervosa, binge eating disorder, and anorexia nervosa, binge eating or purging type, are most associated with substance use disorder. Mental health diagnoses are common in persons with substance use disorder. Eating disorders are understudied. There are few efficacious pharmacotherapies. Data on the most efficacious psychotherapies is inconsistent, and recovery is tenuous. So my recommendation was consider screening all women with substance use disorder for eating disorders, but one could also make a case for screening all individuals with substance use disorder for eating disorders. And thank you for your time. And if you have any questions, I've put my email so you can reach out to me for responses. Thank you so much.
I want to thank our presenter, Dr. Ramsey, for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.